Well, it's shaping up to be an interesting year in terms of the budget, in terms of health care, and we're here to talk about physical and mental health. And I want to start out with a different type of question for Commissioner White. I want to adopt for a moment, say, a skeptical view that some lawmakers have. They'll say every year state agency heads will roll out scenarios of, will issue dire warnings that we're in trouble if our budget is cut, if we're flatlined, people will be affected, and then the cuts are made or the budget increases aren't given, and the world doesn't end, no, life moves on. What's your response to that viewpoint? And tell us what is likely to happen in the coming year, this year, and also in the next fiscal year.
So what the situation is in Oklahoma is that on any given day, we have between 700,000 and 950,000 Oklahomans. Our friends, our family, our coworkers, our children, our neighbors who are in need of mental health and substance abuse services. We have the second highest rate of mental illness in the United States, yet we're funded 46th per capita in the United States to deliver those services. So for those 700 to 950,000 people who need help, only 195,000 get through the door each year to get that help. Only a third of Oklahomans who need mental health and substance abuse care are able to receive it. So as we talk about things being dire, they're already dire. The system only exists for those who really need the help and are the most ill. We aren't doing early intervention. We're not able to do the prevention we need. 2 years ago, as a result of not funding the maintenance money that we needed, 25,000 kids in Oklahoma had their services limited. 25,000. That's 25,000 families, and so while they may not feel it at the Capitol themselves, those families felt it. This year, with cuts that we're experiencing, we know thousands more are experiencing those cuts. Oklahoma families who maybe don't have the same voice or the same opportunities to make people aware, but families are feeling it, and we can't let this continue.
Director Gomez, what's the picture for your agency? I mean, you're probably, arguably, the biggest safety net in this state.
Well, we have a very large budget. So first, let me say, David, thank you for hosting us. What an incredible crowd, and I know you got some folks following online, and it just really makes me feel better that people are very engaged in this topic and very engaged about the health and healthcare future of the state of Oklahoma. And so I'm very thankful to be here and be a part of the conversation, because it's very important for us to have an engaged citizenry about the kind of government services they expect and how they want to fund them. So to answer your question, we've, since the last revenue failure occurred in 2010, we ended up having to make some really drastic cuts then, cut some provider rates, some other things. But since 2010, we have cut $450 million out of the program. Now, this is a $5 billion program, so I understand it's still significant. Really, we've cut $363 million in just the last 18 months. And frankly, I'm proud. I know Terri and Commissioner White and I have talked about this. Proud of the fact that we've really been able to mitigate the pain by doing really smart things. Both of our administrations of our agencies are probably the leanest in the state, about 2.5% admin costs. We really look to make sure that most of the money gets out to the providers. And so I think it's a credit to our providers who are sticking with us and seeing our kids and our adults, our seniors, our individuals with disabilities, despite some of the pressure we're putting on them financially. So to get more specific, to answer your question, what I'm looking for, obviously we've cut rates significantly. We had a 3% rate cut January 1. If we anticipate additional revenue shortfall for the next year or less revenue than last year, then we can expect more provider rates. At some point, those providers have to make a business decision on whether or not they're going to be able to stay with us. And so to give you that, we take care of over 800,000 Oklahomans each month, over 500,000 kids, and it's income-based. So we're talking low-income families, and we're also taking care of seniors in nursing homes and individuals with disabilities.
What happens? Do these children just not receive any services? Are there just fewer services available? What is the
No, it's an entitlement program. So we have a responsibility as a state that says if that child walks through the door and they qualify for the program, it's the state's responsibility to make sure they have access to the health care services they need. And so that's going to be our challenge, is making sure that access to care is available for those kids.
Where it becomes challenging when you look at mental health and substance abuse specifically, and what you hear Director Gomez saying is they're at risk with their provider rates of providers closing their doors. So while they guarantee access for kids, if we get into a situation where providers aren't available in communities, it becomes really challenging for those families to get to those services, to avail themselves of those services. In addition, in our world, the Department of Mental Health and Substance Abuse Services, we have our partnership with our sister agency around the entitlement, but we also are the state safety net for people who have no other resources, meaning they have no insurance, they have no funds to pay themselves, they don't have Medicare, they don't have Medicaid. They have nothing else except the state safety net, and that safety net keeps shrinking. And when that safety net shrinks, for those kids who have no other means, no Medicaid, no anything, services are actually lost.
So when you go into the doctor's office or into a hospital, you're shown a chart on the wall with a rating for your pain, 1 through 10, and you're supposed to select it. How much? So my question to you, both of you, would be, if you were to, by this time next year, what will our level of pain be for people?
It's going to be bad, but I don't know how to put that in context. As you know, Commissioner White and I were talking earlier, the pictures that we used to promote this event tonight were taken years ago, and it doesn't seem like it was that long ago, but we've aged a lot in just the last few years as we've dealt with this budget, and we'll age some more because the people at both of our agencies care so very deeply about the people we're trying to take care of, and we want to make sure we mitigate that pain as much as we can. It could be very painful. We're talking about a $1 billion shortfall at least, probably more. And then you got education. Is education a priority with legislators? How's that going to work with public safety and transportation? Where do we fit within the priorities in a very limited budget, which could be a very economically painful for our providers? And then obviously, if it's economically painful for our providers, it could be, from a healthcare standpoint, very painful for our what I call our MVPs, our most vulnerable people, our most vulnerable population, but they're the most important people that we really care for.
Commissioner White, in mental health, what will our...
So when you think about that question, and you think about it from the perspective of looking at it as a state, we're funded 46 per capita now, as I just mentioned. I'm not sure how bad it has to get before we decide that we have to change that. And if you're a family whose loved one is losing services, if you're part of the narrowing of that door, you're at a 10. And I look at the things that are happening as tragedies around the state, and we've unfortunately had some real tragedies in Oklahoma the last few months. The tragedy that happened in Stillwater, the loss of my friend and many of our friends, Mark Costello. These are tragedies that happen when we don't provide services, and those families, I can't imagine they're anything except at a 10 when they rate that scale. But we know that when we do provide services, good things happen. People can and do recover every single day in Oklahoma. We have thousands of Oklahomans living in recovery. We have people in this room living in recovery who are taking care of their families, who are participating in their community, who are employed. And so when you think about, when you ask to rate that scale, what's the cost of someone being fully engaged in their life versus dealing with the tragedies that happen when we don't provide services?
So one of the big questions that always comes up is, we haven't expanded Medicaid. Now President Obama has sweetened the deal. He'll give us the full funding for 3 years. Any chance, any signs that you see on the horizon, Director Gomez, that...
I thought you were going to ask Commissioner White that question, but no. It's an important conversation that we have to have as a state about how we take care of uninsured Oklahomans between the age of 19 and 64. Medicaid expansion under the Affordable Care Act was designed to meet that need and provide some funding for states to do that, 100% for the first 3 years and eventually down to 90%. What the president proposed in his budget says doesn't matter what state you come in, the first 3 years are 100% federally funded. I expect Congress will ultimately deal with the president's budget in some way. I expect at some point Our state legislature and the governor will continue to wrestle with this issue. The Oklahoma Hospital Association has put a plan on the table about leveraging Insure Oklahoma. Insure Oklahoma is a great program. It's been around since 2004. It was funded with a tobacco tax increase approved by the voters. To serve that population that the Affordable Care Act was, we were actually ahead of the game in trying to take care of working Oklahomans. So I think we ought to look back at the infrastructure we have, and if there's a way to invest in Insure Oklahoma to meet that need, then absolutely. And we can deal with how we get the federal funding to do that, to support that.
You have a big ad campaign going now for Insure Oklahoma.
I do.
Enrollment is what, about 17, 18?
Yeah, it's actually, we're getting close to 19,000. So I'm very proud of that because, we were at 30,000 a few years ago, and then we had to make some changes in the program to accommodate the Affordable Care Act. And so now we're starting to see growth in, and what I hope to announce in a couple months is that we actually have a long-term agreement with the federal government for Insure Oklahoma. A lot of the businesses we've talked to says, Insure Oklahoma right now only has federal funding each year. Nothing is guaranteed beyond that. So we're working on a long-term agreement with the federal government to secure federal funding for a multi-year deal to give businesses some security that they're going to provide a program that's going to be available to their employees.
Well, that's some news right there. Of course, it's funded to the max at $30,000 now. So how are you going to get more funding to be able to even expand the program?
Yeah. Well, what I heard today announced, and I haven't had a chance to talk to Health and Human Services Secretary Klein for the governor, that he talked about a $1.50 tobacco tax increase. Part of that to fund teacher pay raises, and also part of it to fund Insure Oklahoma. So there's some funding right there if the policymakers are interested in that.
Commissioner White, one of the issues on the table now, as you well know from recent meetings, is the cuts in reimbursements or the elimination of allowing private providers for Medicaid services. So why this cut? Did you look at any other cuts, and what are services going to be disrupted for people?
I think that's a really important question. First of all, it's a misnomer to say that we're cutting the private providers out. The vast majority of our network are private providers. We have hundreds and hundreds of contracts. So it's really not about private providers, because that's pretty much all we have in terms of delivering services. The reality of what's happened in our budget, as many of you all know, is that there's been a revenue shortfall that has required that every agency take a 3% cut to their general revenue funds. What that means for the Department of Mental Health and Substance Abuse Services is that between now and June 30th, with a budget we already have in place to serve Oklahomans, we have to rip $9.8 million out of it. As Nico said a little while ago, we actually have the smallest administrations of any state agency. It hovers right around 2.5, 2.4% for our administrative budget. We have over 97% of our budget out in services in communities, delivering services to adults and children who need it. So when we have to narrow the door, the first thing that we do is administrative cuts. And when you look at how we ended up actually taking the cuts of the $9.8 million, $4.4 million of it is being taken directly out of the Department of Mental Health and Substance Abuse Services, either in our state offices, in personnel savings and administrative savings, or in the services we deliver for the handful of facilities that are state operated. So a significant portion of that cut, it's a higher proportion than our administrative budget, is coming out of the department first. There are multiple other things that we're doing. Unfortunately, we had been really planning and trying every place we could find a penny to put together to expand mental health courts in this state. We only have mental health courts in 16 counties in Oklahoma right now. That means if you live in the other 61 counties, I think I did that math right in my head really quick, someone can correct me if I didn't, you don't even have the chance to go to mental health court. You end up going into the prison system, because that's who goes into mental health courts and drug courts, or people being diverted from corrections, which ends up unfortunately costing our legislators more money. So we were desperately trying to put a few more mental health courts out there. That money's now gone. It's been sucked up by this cut. Systems of Care program, desperately trying to help kids. That money's gone, sucked up by this program. We actually had to cut our prevention services. One of the best places to invest is before people get sick, but when you have to provide that safety net, which is our job. The Department of Mental Health and Substance Abuse Services, very clearly the responsibility lands on us for safety net services. You have to look and say, okay, what is the way that we try to keep services in place for those most in need? And when you look at the acuity of kids, the bulk of the kids who are actually in foster care, 80% of those kids are getting services in the agencies, as opposed to individual clinicians. When you look at the data that shows what percent of the clients being served by individual clinicians, only 10% of them are foster care kids. Now, don't misunderstand me. There's kids out there who aren't in foster care who desperately need help. But what's going to happen is there's going to have to be a migration of those in need, because as Nico talks about, those kids who receive Medicaid are entitled to those services, but it's going to have to be a migration of pulling this together, and the backbone and where the highest acuity of all of those resides are in the agencies, the private agencies that are serving people. There is no cut that we have in front of us that's a good cut. Let me make this perfectly clear. The only choices we have are terrible choices. What we're doing is making the least terrible of these cuts. And I'm sure that I assume the legislature feels very similar where they are. They only have terrible choices in front of them of if they're going to make cuts, of how to make them. But what I think is, and what's been hard for me the last few weeks as we make these cuts, I didn't become the Commissioner of Mental Health and Substance Abuse Services because I wanted anyone to lose help. I became the Commissioner because I want to make sure that we change our state from 46 funding per capita. My goal is if we're the second highest in mental illness, we're going to get the second highest funding per capita one of these days, and then as those rates drop, our funding can drop. As soon as we get people to the help they need, people get better and then use less services. There's a way to completely turn this ship around, but as you saw in one of your fellow newspapers' coverage over the weekend, the mental health and substance abuse system has been underfunded since its inception. It's not a situation created by our current legislative leadership or our governor. In fact, our governor currently has fought harder for mental health and substance abuse than most governors have. And in fact, our legislative leadership has protected this agency compared to other agencies from the size of cuts, but we're still taking them. And so when you have a system that's been underfunded from its inception, literally 100 years, if you haven't seen this article, it is worth reading. The only way to get out of this situation is a planned, sustained investment that is going to yield us so much in savings in the long run from multiple areas, whether it's corrections, whether it's foster care, whether it's people losing their jobs and then becoming eligible for Medicaid, people losing their homes, from all of these other costs. There is a way to do this, but it's going to have to take some serious, sustained investment, and that's why I became the commissioner, was to get us to that point. That's the work that we've been doing. And I think currently we have people who understand that, but we have this incredibly disastrous budget right now at the same time.
Terri makes a great point. I want to jump in real quick, David, just to say, you know, Medicaid's counter-cyclical. It's designed to be a safety net for when people are struggling financially. And we've got this situation where we've lost federal funding. And so let me take one step back on Medicaid.
Because the economy was better.
Right. So the Medicaid program is funded partly by federal funds and partly by state funds. Right now it's about 60-40, 60% Fed, 40% state. We have to put up the state dollars in order to get the federal dollar share. When I first started the Healthcare Authority back in the early 2000s, I mean, our matching rate was up in the mid-70s. And so and it's based on it's on a formula. So a 3-year rolling average of the state's per capita income compared to other states. We've been doing well economically. I'm sorry, I keep hitting the mic. We've been doing well economically. And because of that, the formula says you get less federal funding. And so we've had to replace federal funds with state dollars because the need of the people in the state of Oklahoma living in poverty has not stopped. It has grown. We have more kids living in poverty. And so what I worry about is not only just funding the program that we have coming up in front of us, but being able to deal with now the oil field workers who now are unemployed, and those kids will now qualify for sooner care. How are we going to be able to take care of what I anticipate is growth in the program because of the economic factors going on?
So what are we going to see from Medicaid in the coming fiscal year? I mean, your enrollment has slipped a little recently, but our
enrollment's flattened out. And so I'm kind of holding my breath, hoping again that we don't see more people enrolling just because they qualify. But if they need it, they will, because we will be there to take care of them. But can we afford to take care of them? That's always going to be the question. So what I'm looking, obviously we were very proactive. We started talking about this in September, about our budget going into 17 last September, when we saw the writing on the wall saying we're going to have some funding issues. So we tried to get to a flat budget. And so the board and their foresight and leadership said, okay, let's take a 3% cut over 18 months rather than a larger cut over 12. And they passed that in December. We had a 3% provider rate cut. That was before the revenue failure. So all the money that we did take that action to save towards 17 has just gotten eaten up now by the revenue failure. So now that money that we were planning to save for 17 now has to be cut in 17. What I worry about is even this last quarter of this fiscal year that we have another revenue failure. And then what do we do? I mean, because it's federal regulations, federal dollars, there are certain things that we have to do in order to comply for federal funds and notification and things of that nature, the processes by which we're going through. So what I see coming forward is deeper provider rate cuts. I just don't know how deep. But
won't there be, well, Commissioner, let me address this to you, with the cuts from for providers who are not contracted with your agency, won't the impact be greatest in rural Oklahoma? Aren't there gaps? I mean, you look on a map of your community mental health centers, and there are gaps in the rural areas. And then if you take out the private providers too, isn't it going to be more severe for them?
Yeah, so again, in fairness to my community mental health centers, the majority of them are private providers.
No, I understand
I think
that.
it's important that we remember that they choose whether or not they contract with us, just like anybody chooses whether or not they contract with us. And when we talk about rate cuts, one of the things that I think is important to remember is that the Medicaid rates, many people in this state fought to get them to a rate where people would stay engaged in urban and rural Oklahoma as providers for the most needy population. And as those rates get cut, I know one of the things that Nico's worrying about is, will people stay engaged? Well, the mental health Medicaid rates were significantly lower as a percentage of Medicare. In fact, originally we started out, I think we finally gotten to 96% of Medicare for Medicaid rates. We're now down at 89.
No, we were at 100% back 2006.
Okay. We've gotten all the way to 100% and are now down to about 89%.
Now with the last cut, we're just north of 85, so around 86%.
The mental health rates as a percentage of Medicare are at 71%. They are by far lower than any other sector of healthcare, which is unconscionable, and it has to do with the stigma around mental health, I believe, and just the way the system has been underfunded from the beginning. So our providers in urban and rural Oklahoma are on the edge. Now, don't misunderstand. What you have in the areas, every county in Oklahoma is covered by a community mental health center, period. And if you meet the criteria, you will get services, but they may not be locally, so then how do you travel to them? How do you make this happen? And even in urban Oklahoma, we have people who can't get into services because they're not ill enough, or they can't get there even though the services aren't as far as they are in rural Oklahoma. They don't have the money for gas even in Oklahoma City or Tulsa. So what we have is a system across the state where people are struggling to get help and can't get it. And in rural Oklahoma, one of the things I think is really important that existed prior to any of the revenue shortfall and failure, there are only 20 practicing child psychiatrists in the entire state of Oklahoma, period. There are 20 practicing child psychiatrists in the state of Oklahoma. They do not all contract with us. I can't entice them all to contract with us because of our abysmal rates. And most of them do live in urban Oklahoma. So regardless of what's happening, or not regardless, but in addition to the revenue shortfall, they don't exist in rural Oklahoma, but prior to the revenue shortfall or after. And so we are doing really creative things. We have the largest telemedicine network of any public behavioral health agency because we're desperately trying to get services to rural Oklahoma. But rural Oklahoma, absolutely I'm concerned about. I'm concerned about every area of Oklahoma when we only serve a third of the people who need help for mental health and substance abuse issues.
I'd like to open it up to questions from the audience. We have Evie Holzer, Jenny Nygren, and if you have a question, they can come to you with a microphone.
Evie.
Okay, there's a question here.
Hi, my question is for the Commissioner, Terri White. Why not cap the agencies at individual services and be more equitable with the dollars across the board to preserve the other private providers that are in rural Oklahoma and are in other sectors, urban and everywhere, that are providing safety net services?
It's a great question. There's a couple reasons why the decision was made the way that it was. And it really isn't about providers. Now, as I say that, realize my employees are providers. Providers, no matter what type of provider you are our partner. So I get that. But the question really is about the people who need services. So we ran the data of where the kids are who are the most acutely ill. And the data is very clear that they're in the agencies. And so when you're forced to narrow a door for a system that is supposed to be the safety net, we preserved the services for the kids who have the highest acuity and the highest levels of need. And that's why the decision was made. It was about where are the kids who are the most ill getting services. Now, when you look at that, can you find a kid who's just as ill? Absolutely. Will they have to migrate? Absolutely. Do we wish that we could just serve all of those kids? Yes, because keep in mind the kids that are getting in this system now, because we're only serving a third, are the kids who are the most ill. So none of them should be losing services. But when we have to make a decision, we have to preserve them for those that are the most acute. In addition to that, one of your questions is why not cap? Well, one of the things we were just talking about is the rates at which we pay. The rates are already so low, no matter what type of provider you are in behavioral health, that we have providers at risk of closing their doors completely. We are only at 71% of Medicare. When you look at our surrounding states, we are low. We're low compared to other physical health issues. And I'm sure that you know this, if you've provided or sought services, have you ever seen most of our mental health and substance abuse providers? Meaning the facilities, they're not beautiful healthcare facilities like we have in some healthcare facilities around the state, right? They don't look like the amazing life-saving services that are happening on the inside. They're often think about abandoned strip malls where you then see a mental health or substance abuse provider setting up because that's the only place they can afford to pay rent because our rates are so on the margin. So when you look at making rate cuts, what you risk is doors closing completely. And so then it's not just a lack of a particular service or who is the provider type, it's services as a whole that are then not available in a community, whether it's rural Oklahoma or urban Oklahoma. It was the least terrible of all terrible choices given all the data and all the research that we've done. What I think we have to be talking about is how do we ensure that we either fix it so that we don't lose any more people out of services and get people back into services, because the whole discussion really should be, if we're in a tight budget, how do we as a state, which I wish I had the power to do. If I had the power to do this, the door would be getting more broad as opposed to narrower because it will save the state money and it will have better outcomes for families. But that's not the situation that's being forced upon the Department of Mental Health and Substance Abuse currently by the revenue shortfall.
We have a microphone right here.
Yeah. Hi, I was wondering what data are you using to base that on?
So all clinicians, no matter what setting they practice in, submit their acuity data in multiple ways. They have to get prior authorizations and they authorize a level of services. They do assessments to the CDC is just part of it. And I wish I could tell you off the top of my head every single data source we have, but I can grab some folks afterwards and get that information to you. But we look at the services that are authorized, we look at the services that are billed down, we look at the array of services the child is receiving, because we luckily have one of the best data systems in the nation. In fact, the Department of Mental Health and Substance Abuse Services has the most comprehensive public behavioral health data system of any state in the United States. When we have universities from around the country who like to work with us to do research in terms of data research because it's so comprehensive. So we have a really good data on what services people are getting. We know down to the individual, we know the date, we know the services, we know the outcomes. We match our data against OJA, we match against the Employment Securities Commission, against DHS, against OSBI for arrest reports, DOC, so we know what's happening in both the adults and kids that are touching our system. So we have really comprehensive data that shows that, and what's really troubling is that data, while many of us understand it, hasn't translated into the investment that needs to. I don't mean just recently, but I mean over the last several decades, because this data system isn't new, it's very comprehensive.
Commissioner Gomez, I'd like to ask you, behind the scenes of all of the current debate over provider rate cuts, we have a process going on to essentially privatize care for the aged, the blind, disabled with an HMO-type system. And people look back at the 90s and say, HMOs did not work in Oklahoma. Why do you think they would work now?
Well, let's take one step back in history. Whenever we had fully capitated managed care, in which we as a state contracted with health maintenance organizations, HMOs, MCOs, managed care organizations, to take care of our senior care members in Tulsa, Oklahoma City, and Lawton, those kind of metropolitan areas. And frankly, that worked. We saved money. We got good care, got good outcomes. What eventually happened is we could no longer afford the actuarial rate increase. So I want to be careful so we don't misunderstand. It did what it was supposed to do. It saved us money. It taught us a lot of things about managed care. It just became an issue where we could no longer afford it using kind of that third-party MCO model. The legislature directed the Healthcare Authority to do an RFP on care coordination models. We selected a managed care model to look at that, and we're in the process right now of developing an RFP, which I expect later this spring we'll have it out draft, and we'll put it out in the market and see what the market has. I mean, I think it's okay for us to look at our program side by side with the private market and say, if somebody can do it better and less expensive, then we obviously need to look at that. So that's the conversation that we're having. Obviously, we're going to go in with a cautious eye, because obviously it's a budget situation, and we want to make sure we don't spend more money than what we're spending today, but making sure that we achieve better outcomes. We have folks who we categorize as age, blind, disabled, or individuals with disabilities. Again, our MVPs, our most valuable people, most vulnerable people, where we want to make sure they're getting taken care of. Then we have some folks who are both what we call dual eligible for Medicare and Medicaid, and we know we could save some money and improve health outcomes by better care coordination. And so we're trying to test the market to see what's out there on that care coordination side. So,
question here.
Yes, when these private providers and their patients are going to start moving to agencies for employment and for services, are there going to be any resources provided by the DMH or the OHCA for those providers and patients during that process? And has there been any thought to maybe easing some of the regulatory burdens to allow creation of smaller agencies to be a little easier, so that if those private providers did want to join together to create smaller agencies, that there would be a way to make it easier for them? Obviously not in maybe some of the financial incentives, but maybe just make it easier for their creation.
Yeah. We work on, and if any of you all have any ideas, we are taking any and all ideas you have on anything related to efficiency. The department has a long track record of being incredibly efficient around the use of administrative dollars, and also continually looking at trying to lower the burden on providers while still meeting basic regulatory requirements. We have one of the least expensive certification amounts. As you know, when people get national accreditation for their agencies, they pay thousands and thousands of dollars. In Oklahoma, to be certified by the Department of Mental Health and Substance Abuse Services you pay $300. That cost doesn't even cover what it costs us to send people out to certify these entities to make sure they're meeting basic health and safety requirements. So we have purposely kept that certification fee low. Arguably, it's probably too low, but we would need legislative authority to raise it. And that continues to be challenging to look at any sources of raising revenue for mental health and substance abuse services or any other service. So we absolutely would look at any suggestions. We continue to look at it on a regular basis. When you talk about smaller entities, we actually have very small agencies now to very large agencies. So we'd be happy to talk if there's something specific you have in mind. But I know that there are small agencies and large agencies in our system now. When you say provide resources as the transition happens, I don't know specifically what you mean. I can give you some examples of things that Nico's agency and I are doing together. We are sending letters to everybody that's affected. We are making sure that they know where to call, they know who to contact if they want to talk about transitioning their services. For those kids that do have severe emotional disturbance as identified by their clinician, which is not the majority, we will be personally reaching out to those families as well, because those are the kids that are the most in need. But any other suggestions you have, we're happy to talk more about. And again, this is These are not cuts that we take lightly. These aren't even cuts, and I think I've been pretty clear about this. These aren't cuts we want to make. We don't want to have to cut anyone out of services, but it is our responsibility and to look and to see the way to do it to have the least impact possible, which is really painful when you only serve a third of the families that need help in the first place. There is no way to make cuts to the mental health and substance abuse services budget of any decent magnitude, and I'm not even sure I want to use the word decent when we're talking about cuts, but of any sizable magnitude that isn't going to hurt Oklahoma families. And I thought the question was such a great question earlier about when people say disastrous things are going to happen and then they don't see it. You all are seeing it. You saw it 2 years ago. We had people who protested our cuts 2 years ago. You're seeing it now. I don't know how much more clear to make how desperately families in Oklahoma need these services.
Commissioner Gomez, if you were to predict what percentage cut you would face in fiscal 2017, what might it be?
Well, I mean, I really just hate to speculate. I mean, we cut 3% to try to get towards 17. Obviously, now it's just going to, we'll get our
fiscal year 17, not a 17% cut.
No, not a 17%. And when we started looking forward to fiscal year 17, thank you for the clarification. Yeah. I just really don't want to speculate. I think until the governor's budget comes out, it gives us the best idea of kind of, for me, I think what our ceiling is. And then obviously the legislature has to go through the process of negotiating a budget. I don't think it's out of the question to see a 5 to 10% provider rate cut. Those numbers are having $1 billion, $2 billion less dollars to spend. I don't see how you're not going to have some sizable rate cut. Now, the reason we're at rates is because in the entitlement program, there are federal requirements on who you have to cover, and we're really kind of at the federal minimum of who we have to cover as a state, very conservative number of people we cover. There is mandatory benefits that you have to provide in order to qualify for federal funds. For the most part, we're at the mandatory benefit, and so now we're down to rates. And so anytime we have to cut from here on out, it's usually with rates. But to tag on with what Terri said, if folks have ideas about things we need to look at, about making sure that we have turned over every stone about here's a way we could save money and still protect services, still protect people, I want to hear it. And so let me give a quick plug for the website, our Healthcare Authority website, okhca.org, okhca.org. Google Sooner Care, you'll find us. And my email address, nico.gomez@okhca.org. Send me your thoughts, send me your ideas. We want to make sure we've got them covered. So.
Yeah, and just because he's sharing the website and the address, mine is available too at www.odmhsas.org. And my email address is on there. You just have to Google leadership. It's TL White. Make sure you get the L in there because otherwise it goes to my records clerk in Woodward, Oklahoma, whose name is Tonda White. So it's TL White at odmhsas.org.
I think for a lot of people, your agency, yours, are very complex. For providers, certainly they understand it more, but I think for others, it's just a hand-wringing. I would venture to say they look. We're 45th ranked in the nation in health outcomes. We have problems with suicides. We have high obesity rates, cardiovascular, diabetes, firearm deaths. You name it. And so these are the people who are affected, and they say, why can't something be done? Do you ever go to the lawmakers yourselves or the governor and say, look at this, can we do something? Can we raise taxes? If that's the answer, raise revenue in some other way?
Our budget hearings are public hearings, open to the public. If you have not come to a budget hearing for the Department of Mental Health and Substance Abuse Services and you are upset that we are being forced to cut the budget, I would suggest that you engage in the process at the point that it starts, because telling us not to make cuts when we're already mandated to make them, I can't undo it. I have no authority to do that. If we have to make the cuts, we have to make the cuts. So if you don't want anyone to lose mental health and substance abuse services, or more so, if you would like to do what I did a couple weeks ago in our Senate budget hearing, which was open to the public and covered by the media, and ask that despite this budget challenge, we open the doors wider and get more people in, come and join that effort. And so as we talk about ideas, we want ideas if we have to make cuts, but I think what Nico said at the beginning about thanking you for doing this and having such an engaged populace is really important, because there is no cut that is going to happen to the Department of Mental Health and Substance Abuse Services that isn't going to result in someone losing a service. And rather than turning on each other and fighting about which person gets to lose those services, I think it would be much more effective for us to all work together so that nobody has to lose services.
Yeah, and I like to add on, I've never had a conversation with the governor or with any legislator that didn't understand the problem. They really don't. I mean, they understand the issues, but they're elected officials. They're representing the people who are engaged in this conversation. And if you're not engaged in this conversation, then they're only able to represent who's talking. And so that's why it's really incumbent upon all of us to be very engaged in this conversation, more than just the people in this room. I'm talking about from Hollis to Woodward, everywhere.
And speaking of engagement, any other questions?
We have a question right back here.
Okay.
I was curious about the total number of kids that will lose services with this cut, and also what would be the impact if we actually did a percentage cut across the board to all providers?
So when you look at what the changes are that are happening of cuts right now, the kids who have Medicaid coverage, if they need the service and engage the service, will be able to access the service. So when you say what will the number of kids be, it's hard for us to predict the number of families that won't engage or won't be able to engage. But the kids who have this coverage are guaranteed the service if they medically need it in terms of medical necessity, and it's assessed that way, and they engage the system. When you talk about the percent of cuts, it just depends on which providers, because different services are set at different levels. We have to cut $9.8 million out of the budget. We have to rip that out. That has to be the total number. So if you're saying we take this cut and just switch it to a provider rate, the total cut for this is estimated to save about $1.2 million over 4 months. So we'd have to switch and cut $1.2 million out of provider rates. The problem that we have, as we talked about earlier, is these rates are so on the margin that one of the things that I think is not a responsible way to approach this is to just do across-the-board provider rate cuts, no matter what size of cut the agency gets, as opposed to looking and saying, how do you preserve the services for the kids that are most in need or the adults that are most in need so that you're truly the safety net system?
Let me go ahead and add on so people understand the context of the budget. So when the legislature appropriates dollars, they appropriate some dollars to DHS for the Medicaid program, for the administration of the Advantage waiver and some other programs. For behavioral health, for outpatient behavioral health, the legislature appropriates dollars to Department of Mental Health and Substance Abuse Services, and then the rest of the Medicaid program to the Healthcare Authority. So when we make cuts to the Healthcare Authority, don't necessarily directly impact DHS or Department of Mental Health and Substance Abuse Services. So for us, for every 1% rate cut, it saves us about $8 million state dollars. So when we're talking about if we've got a $80 million hole next year, that's a 10% rate cut.
I want to mention one thing. There was a bill introduced recently. We just stumbled upon it that was surprised to us, and I want to ask you for your reaction, or Commissioner Gomez. This was by Representative Cox, who's an emergency physician. And he proposed a bill that would ask your agency to promulgate rules that eliminates benefits for any non-pregnant, able-bodied adult under 65 years of age, as well as require the same for the Oklahoma Department of Human Services. Are you familiar with that bill?
I'm not familiar with that.
Okay.
Now, I'm in the process of going through bills, but I'm not familiar with that. So I have not had a conversation with Dr. Cox as far as what his intent is.
Okay.
So if I read that right, he's saying that, or not saying that one more.
No Medicaid for anyone under 65 who's able-bodied.
Yeah.
So I guess my point is, whether you know about it or not, it just seems like the effort continues to be, whether it's the blind and disabled and it's the HMO type system, or it's this bill, we need to keep pulling back on the costs over time, beyond next year and the next year and the next year. Is that what you're looking at, is to basically to find efficiencies for the next 3, 4, 5 years?
Well, I would love to sit and think about, a 5-year plan, but the way we're appropriated, it doesn't work that way. And so when you try to plan ahead and then you get hit with a revenue failure, totally blows all that out the window. So I think I understand what Dr. Cox is saying. He says if you're able-bodied, that you're not disabled. Well, obviously, if you're able-bodied, you don't qualify for Medicaid. You have to have a disability, qualifying disability, in order to, as an adult, to qualify for Medicaid. So I'm not exactly sure what his intent is there, but we have pregnant women. Did he say non-pregnant?
Non-pregnant.
Non-pregnant women? Okay. So I'm not exactly sure who he's referring to.
Other questions?
So, Mr. Gomez, it seems like people living with disabilities and health conditions and their families would be the experts. So who gets to decide what is best services? What are better services?
Well, I think number one, it's a community conversation. So we actually have a very robust website where we can get public comment, where we hear from the experts. We have a medical advisory committee, which I'm sure a lot of people were at last week to talk about some of these. I think it's, for us, for the Oklahoma Healthcare Authority, when we started going through these cuts a few years ago, I think you can ask every provider group that is contracted with us. We went and talked to their association. We went and talked to their members. And we went and talked to families. We meet quarterly with a group of members, parents, who have families, who have kids in the program, and we talk about the things that we're facing, and we hear from not only the providers, but we hear from the families on a regular basis, not just when we're in crisis mode, but on a regular basis. And so we do look to the families, we do look to providers to give us guidance. At the end of the day, the buck stops with me in terms of after the legislature gives me the budget, I'm the one that has to make the decision to file the balanced budget on behalf of the Oklahoma Healthcare Authority.
There's a question in the back first, and then we'll come to one here in the front.
If our state accepted the Medicaid expansion, would it prevent us from having to make these cuts?
Well, what it does is it provides 100% funding for a population we don't currently cover. So, well, except through Insure Oklahoma. So it's not going to necessarily provide extra dollars for the Healthcare Authority. I can't speak for the other agencies and how that might impact them. Commissioner White may want to address that. But what it could do is put more money into the healthcare economy in terms of, if we're going to cut dollars out through the Medicaid program to the Sooner Care program, then you actually could put more dollars into the program by covering more people with federal funding.
Question here.
Commissioner White, if all the LBHPs or the majority need to end up going to a state contracted agency or become one, how will that end up saving us money and cut the budget like you're saying?
So there's two ways that this will happen. One is the migration of services. We know that anytime you change service providers, people don't always migrate and seek out the service on their own. So we know that the research shows that that's going to happen, which is, again, why we shouldn't be cutting this system at all, right? We shouldn't be losing services for anybody who needs mental health and substance abuse services. The other thing, because we're the state safety net, and there are dollars in the agency to serve those who have no other means of service, if everybody who migrates over has medical necessity, then people who have no Medicaid coverage, who are the least ill, will lose those services. So there will be somebody who loses services through this, but it may not be a Medicaid child. It may be a non-Medicaid child who has nowhere else to get those services. That's what happens when this budget's cut. Now, one of the things I want to say that I think is really important that Nico mentioned a second ago, we have a governor who does care about mental health and substance abuse services. She's talked about it more than most governors ever talk about mental health and substance abuse. We have legislators who care about this issue. However, as Nico said, they are representing the people who elected them and the people that they're hearing from. And so one of my questions that I try to wrestle with on a regular basis is how do we get them the support that they need to be able to protect mental health and substance abuse services from cuts? And that's a question I think we need to be asking them, is how do we help them help us? And that dialogue has to take place before decisions are made about the budget, not after decisions are made about the budget. And I think it's really important because there's a lot of people at the Capitol right now. In fact, when I came in here earlier tonight, somebody was telling me, there's a large discussion happening about whether or not there's going to be a teacher pay raise. And I have a little boy. I understand the importance of education. But we have families who may lose their health care services. When we talk about suicide, when we talk about other things that are keeping their kids or their parents alive. So how do we make sure that these issues, or at least I won't speak for Nico, although we're partners, so maybe I'll speak about the whole body right now, as opposed to brain health, which is normally what I speak about. How do we ensure that the health and safety of our population is addressed as well? And that is where we have to get an engaged populace, and why this discussion is so important today.
Well, these issues are tied together. You can't fix education in a silo. You can't fix healthcare in a silo, because if you don't have a healthy kid, they're going to struggle with their education, and then ultimately that's going to impact our workforce. Then you're not going to have a healthy and productive workforce. These are all issues tied together. They can't be solved in a singular view.
A question in the back.
Yes, this is for Terri White. You spoke, obviously the cuts have just been made with the independent private practitioners. Can you speak to what may be on the table in the future as far as cuts?
One of the things, as you know, we're wrestling with, and I'm sorry I cannot see you. I try to look at people when they're talking, so they're
in the back corner.
Oh, thank you. Okay, I can't see you partly because of the lights, but also I just can't see you based on where you're sitting. But one of the things that I think is really important about the way we approach cuts, obviously, as you've heard me talk and said multiple times tonight, is about the safety net. So what we're wrestling with now, and what the Capitol is wrestling with, and what we hopefully will know more about after the governor's budget's released on the first day of session for her recommendations, is what size of cuts. And when you asked the question earlier about what percentage of cuts do you think we're going to experience, it is really hard to know at this point. And I'll be perfectly honest with you, and Nico may not feel this way, I'm only speaking for myself right now, but I'm afraid to put a number out there, because I'm thinking, what if the legislature was actually going to cut, or the governor was going to cut less and preserve help for more people? I'm not offering up a penny right now, right? So guessing at that number is a very scary prospect when you're responsible for this system, when you have more people needing help who can get in the door, and you have to figure out every single day how you're going to stretch these resources as far as possible. So when you say what's on the table clearly is services to families. I mean, we will cut administration again, although we took such a huge cut this round. We took $4.4 million out of the department directly of the $9.8 million. We have very little left, and I'm getting questions about how do we get agencies certified more quickly. Well, if we're cutting everybody out of staff, there isn't anybody there to do that job. So it's like trying to balance all of that. So the majority of what happens, because over 97% of our budget, 97.6%, is in services in communities, either in prevention or in treatment. Those are the services that'll be cut, because that's all we do. That's all mental health and substance abuse does. Its mission is prevention and treatment, and that's what we do with our dollars. So depending on the magnitude, that's where we have to see how do we make it as least catastrophic as possible. And planning for a large cut versus a small cut is a very different process. And until we get some sort of guideline of where we might be in that, which the first indication will be when the governor's budget's released, we're looking at all kinds of options, but I have no idea which ones we're going to implement until we know that size of that cut. But I can tell you exactly what it's going to be. It's going to be services to Oklahomans in need, because that's all we have.
We'll take one more question.
Commissioner White, you keep talking about if it's medically necessary. Medicaid only pays for services that have been determined medically necessary. So these kids that are getting services with the independent contractors, there's already been that determination made. So the other day at the Medical Advisory Committee, you said that the savings is going to come because you feel that 50% of those kids will no longer be getting service. So we're cutting services to kids that have a medical need already established, 50% of those kids.
Right. So all we have in the system now, out of everybody who's getting services, are people with a medical necessity. 700 to 950,000 people need help. Only 195,000 people are getting it. So everybody's medically necessary, right? So with Medicaid, there's a guarantee. So what will happen is some people will not seek out services or be able to engage. So those services will drop that way. The next part is those kids who do have medical necessity will get into services, and it will push out another kid who has no other means to pay. That's how the system works when you have so few people in. So there will be Oklahomans who lose services through this, either through attrition or because they don't have a guarantee of an entitlement program and their family's going to lose help.
I'll ask Commissioner Gomez, at the end of your term in this position, what do you hope to look back and see, and do you have any regrets? Do you think, let me add to that, do you think...
I've only been in the position 3 years.
I know. You're not going anywhere.
We expect you to be there much longer. Do you think that
My predecessor was there 14, you know? I don't know.
will be healthier or not?
We won't be healthier without the right investments. We just won't. We got to be able to make the right, smart investments in Oklahoma to have a healthier population. Part of that's education. But part of that's having a real conversation with the citizens about the kind of governments they want and the kind of government they're willing to pay for, whether it's education, public safety, transportation, education, or healthcare. You know, I have a healthcare hat. I mean, I have an education hat too. I'm a school board member over in Bethany. So I see all these sides. I want to be able to walk away at the end of the day knowing that people were better served because I was there, and that people had access to healthcare because I was there. That's what I want to walk away with. You know, how we get there, I'm not sure how we get there, but I have hope. I have a lot of hope because Oklahoma is resilient. It's going to be a tough issue, but I think given the facts, Oklahomans will make the right decision. We just have to make sure the facts are in front of them and that they're engaged in this conversation with their elected officials. So I have plenty of hope.
Commissioner, same question for you. And I should add that mental health has gotten a lot of attention and coverage in recent years. So what are your hopes? Any regrets? What do you hope to see when you finally, years from now or whenever, step out of the position?
I have to smile at some of our folks who are a big part of ensuring that mental health and substance abuse services has gotten the attention it's gotten. It's very different than the dialogue we were having 10 years ago. We have made progress on public awareness. Are we where we need to be? Does every Oklahoman understand that it's 1 out of every 4 of us? It's 1 out of every 4 of us that struggles with a brain disease each year. It looks like me, it looks like you, it looks like our families, it looks like our friends, it's our coworkers, it's our neighbors, it's members of our community of faith. We're getting to a better understanding of that. What I hope is that that then translates into changing the fact that we currently, those of us in these roles currently, have inherited a system that it has been underfunded for a century. 100 years, the system has been underfunded, but we're the ones standing here now. So what are we going to do to ensure that this system is not underfunded to this extent 100 years from now? And that's what I do think that I have hope about it changing. Despite the fact that we're funded 46th per capita in the nation right now, we have one of the top, they looked at it and they said there are 6 mental health and substance abuse systems in the United States that are the top 6. They didn't rank them among those 6. They just said they're in the top 6, and Oklahoma was one of those. Because of the hard work that our providers put in, because the people who are in this profession care so much that despite the fact they're on the margin, they're engaged and they're staying in this and they're saving families. But what I really hope that we see change is imagine if we were funded currently 46th per capita and we have one of the top 6, I don't think it's hard to think we can get to number 1. We are number 1 in many things around, well, many things besides mental health and substance abuse services, but we are number 1 in several things about mental health and substance abuse services. Our drug courts and mental health courts, national leaders. Systems of care program, national leader. We can get to the point where we are the number 1 mental health and substance abuse system where they'll actually say who's number 1 if we invest and get out of this hole where we only serve 1/3 of the people who need help. We can do it, but it takes all of us engaging and really building on the knowledge and awareness that is now out there that this is a disease like any other disease. People can and do recover, and we can avert multiple tragedies, whether it's headline-grabbing tragedies that we've seen over the last few months, or it's tragedies that happen every day when we lose 2 Oklahomans every single day to suicide. We can avert these if we invest in these services.
Thank you. Please give our guests a hand.